Hello, everybody, dear members of the Swiss Chamber, dear friends of the Swiss Chambers in Hong Kong and in Australia. We are very, very happy to welcome you all to this very nice fourth Chairman's Luncheon, which today is again something where we want to look a bit out of the borders. We want to think a bit out of the box. And we are very happy that we have gained the Médecins Sans Frontières, doctors with Médecins Sans Frontières for our today's Chairman's Luncheon. As usual, it is not just about doing business. It's not just about commercial things. We want to listen as well to some topics which are abroad. And so therefore, we are quite happy that we have something again, which will be very much of interest of all of us. I'm also happy to welcome our ambassador, Fabrice Fillier, who is part of today's
Hello.
Hello, Fabrice. Nice that you're here. And we're gonna have, as usual, a couple of presentations today. We're gonna learn a lot about those great projects Médecins Sans Frontières is doing, and we wanna give you as well the opportunity to ask your question, to do your comments, and maybe as well to just have kind of a dialogue. Before I want to start by introducing our speakers of Médecins Sans Frontières. I want to give the word to Clarissa, our office manager, who will share some information as usual about the administration of our chamber, and then afterwards we will start in medias res. Please, Clarissa.
Thank you, George, and thank you all the participants for joining this very interesting webinar. Thanks to MSF team for coordinating everything and to our two speakers presenting today. So just a few Swiss Cham admin updates. So we have recently closed the Business Excellence Awards. We were very happy to receive 44 applications for the DX Award, Digital Transformation. Our project team is working on the pitching nights, which will be communicated very soon. On the other hand, we are still continuing with the DX Leaders episodes on a weekly basis. The next one is next Thursday with SG Innovates on the 5G topics. Last but not least, our team, together with Nina, our new intern, we are working on the year-end events, which will happen on the first week of December. More information will be communicated soon. It will be a Christmas atmosphere, year-end event with our dear members. So thank you everyone for joining us today, and I give the floor back to George. Thank you.
Thank you, Clarissa, for those updates. So today we talk about Médecins Sans Frontières, and that is a great organization which is very engaged all over the world. More than 70 countries where they do have their projects, and we are very happy that we can learn a bit more today about those activities. We're going to start with Karu Prabhaharan, the philanthropy officer of Médecins Sans Frontières in Singapore, who will share with us a bit more comprehensively and as well how the whole organization is built and works. Afterwards, I will give the word then to Gert Verdonck. He is the interim director of Médecins Sans Frontières Hong Kong Operation Support Unit. He will give us an overview about how the operational stuff is working. What does it mean to coordinate and to organize all that projects? and as well, where is Médecins Sans Frontières actually active. And then we want to have as well, and that's a great pleasure too, that we're going to have some impression about the work on the field. So we will have Vivegan Jayaretnam, who is a project coordinator of Médecins Sans Frontières, and he will share with us a project where he did some nice pictures, and he will tell us the story how projects concretely worked on behalf of COVID-19 in Ethiopia. So these are three very interesting speakers we're gonna have. They will share their thoughts, and we will learn a lot about this great organization. You will have, as usual, the opportunity as well to raise questions. You can do that by chatting them, and then we will moderate them, and we will put them through to the speakers. Or if you would like to get into the dialogue, as usual as well, that is a possibility. Then just to push the button and jump in directly. So let's jump in medias res. Karu, please, stage is yours.
Great. Thanks, George, for the introduction of MSF and the speakers for today. Hi, everyone. My name is Karu, and I am the philanthropy officer for the MSF team based in Singapore. I just want to thank all of you for taking the time today to join this call and find out a little bit more about our organization. And also today with me in this call, you'll probably see them on the screen, are Flaminia, who is our philanthropy manager, and Sarah, who is our comms officer, and they are from the Singapore team as well. And it is also really our pleasure to have with us our very lovely colleagues from the MSF Hong Kong and MSF Australia team on this call as well. So I will introduce them a little later toward the end of the session. So before I pass on the time to our two wonderful speakers for today, I would like to give you all a very quick introduction to MSF and the work that we do. So Médecins Sans Frontières, or Doctors Without Borders, we are an international independent medical humanitarian organization. And MSF was created with the belief that everyone, regardless of your race, gender, political or religious affiliations, should have access to healthcare, and that people's medical needs outweigh national boundaries. Okay, so MSF was founded in the year 1971 by a group of French doctors and journalists in the aftermath of the Biafran War in Nigeria. And today we are a worldwide movement made up of over 60,000 health professionals, logistics and supply experts, and administrative staff like the staff that you see on this call today. And in 1999, we won the Nobel Peace Prize in recognition of our pioneering humanitarian work in several countries. So these are the contexts that MSF works in. We bring free quality medical assistance to people affected by war and conflict, epidemics, or in today's context, pandemics, natural disasters, and we also provide healthcare to people that are excluded from healthcare, such as your migrants and refugee communities. So there's this saying that MSF is first in and last out. And the reason why we are one of the first few organizations that are able to respond in times of emergency and crisis is because we have our own supply and logistics chain. And we can deliver supplies and deploy specialized teams anywhere in the world within 72 hours. And why we are the last out is because we do as much as possible to ensure that the local ministries of health in the countries that we work in have the capacity and proper infrastructure to provide access to medical care for the populations in need. So we provide humanitarian aid and medical care in over 70 countries, and this is just a snapshot of where we are on the map. So with regards to our finances, we are financially independent and transparent. And just last year, 95% of our income actually came from 6.5 million individuals and private foundations. And the donations, of course, go towards the millions of consultations, surgeries, and treatments that are done at our projects. So this is just a quick look at the kind of impact that MSF has had last year. So last year we provided over 10 million outpatient consultations. We assisted in over 3,000 births, over 400,000 mental health consultations, and mental health has recently been becoming an increasingly important aspect of the work that we do. We've treated over 2 million cases of malaria, vaccinated over 1 million individuals against measles, and so on. And in terms of our workforce, we have office staff like the staff from the different MSF offices joining us today. And then we also have field workers who are volunteers that volunteer their time and service, and they come from diverse nationalities. So Vivi is one of them. And although we are called Doctors Without Borders, our field workers actually come from both medical and non-medical backgrounds in approximately a 50-50 ratio. So for medical staff, you have, your surgeons, doctors, nurses, and for non-medical staff, we have logisticians, engineers, water and sanitation experts, and so on. So so that's just a very brief summary of MSF. Later we will share our website details as well, so you can just visit our website and find out more about our organization as well. So now I would like to pass the time on to Gert Verdonck, who is our Interim Director of MSF Hong Kong's Operations Support Unit. And he will be sharing about how MSF's response to COVID-19 has evolved over the past months. So Gert, we'll just pass the time on to you.
Hello, good afternoon, everybody. So my name is Gert. I'm the Interim Director of the Operational Support Unit in Hong Kong. I'll give you a brief overview on MSF's response, on the evolution of the response, and then the challenges and achievements that we faced along the way. So, as mentioned by Karu, I think we work in around 70 countries. This is in the beginning been quite difficult because we need to include COVID activities into the existing projects, which is not always that easy to do, because there are a lot of challenges, whether it's resources, whether it's access. So that's something that evolved over time, as well as 70 countries. Of course, you have seen on the map, majority in the southern half of the southern hemisphere of the world. But COVID is a pandemic, and COVID is everywhere, with a lot of people being affected. Also in the developed countries. So we also had to shift over time our focus on different countries where we were not always used to work. Our priorities always have been supporting the authorities. This is whether it's COVID or no COVID. We're supporting the authorities to provide care. Protection of the people who are vulnerable and the ones who are at risk. So basically the vulnerable people, people that are on migration, that live in camps, that live in conditions that are not the way that that are not standard, let's put it like that. And then the people at risk, of course, elderly people with underlying conditions who are more at risk to become seriously ill from COVID-19. And then, of course, keeping the essential medical service running. it's not because there is COVID-19 that there is no more tuberculosis, that there is no more measles, that there is no more malnutrition, that pregnant women all of a sudden stop delivering. So all these essential medical services, of course, need to be up and running. So how we do that, or how we did that, it's mainly by improving infection and prevention control measures to make sure that your hospital does not become an amplifying factor in the pandemic, to keep your staff and patients safe. Therefore, a lot of different tools can be used inside any kind of health structure. And then another focus, and this evolved a little bit since the beginning, is the no profiteering. What does that mean? At the very early stage, there was this big race towards surgical masks in terms of protection. We noticed, for example, that the tissue that is produced just for these masks, they multiplied by 10 in terms of price. Access at a certain point was only for governments. So that puts a lot of people in jeopardy who are also doing projects like MSF, for example. The tissue that is also used to make protective gowns, a lot of the factories, they stopped making these gowns. So everything becomes, of course, quite expensive. And a lot of times it's the one with the most money who will have access. And at the beginning, this was supply. At the moment, now we are looking more towards medication and vaccines, where we will have to see how it will work. It's gonna have to be the place that is the most at risk, or that is the most touched by the pandemic at that point, that should be prioritized in terms of medication and vaccines. But let's hope it's not utopia. So our achievements and challenges, I think the continuous medical care for our projects, there are very few projects that had to be suspended because of the lockdowns. This was inevitable when you do certain community work, but most of the projects were open. The expertise in handling complex emergencies. So what's that? It's advising of certain health authorities in terms of getting the pressure off from the system that is overwhelmed. And this can be in terms of the real health professionals, as was mentioned by Karu, in terms of profiles, because all of a sudden everybody had to have a lot more staff, which was not there, so you had to change a little bit the things. Or it could be also on the logistical side. One of the examples in my country, and where I'm from in Belgium, was that in some of the specialized hospitals, we put up a laundry street just to make sure that they could wash all the reusable items that were used in the COVID unit, because the hospital is only set up for a certain amount of items. And we did a very basic approach where you just put your buckets with chlorine and you just wash, dry, and then you put them back in the process. You put some washing machines, which seems very basic, but for a lot of countries, this is unseen, and they never dealt with this before. So that's where our expertise really came in handy. And then, of course, the life-saving care in conflict areas and humanitarian crisis. is very important. I'll give the example of Yemen later on, where the war is still running. And then in low resource settings and fragile health systems. A lot of times we think about the African continent, where there is a lot of these countries. On the other hand, they have experience with epidemics, they have experience with health promotion, they have experience with contact tracing. So that gave them a bit of an advantage on other parts. And then, of course, the maintaining and adapting of crucial medical activities. So we brought up a couple of models, for example, on how to do TB treatment in prisons while having COVID. There was also, in terms of vaccination, the Democratic Republic of Congo, we kept on doing our vaccination activities. At the same time, there was also an Ebola outbreak that, fingers crossed, seems to be over in a couple of days. It's been 20 days now, so without any case. But we had to combine, so people could come to the hospital, and you had to put up a triage where you have to see, are you a COVID patient, are you an Ebola patient, or are you coming for any other kind of consultation? So that's a very, very complex, but one of the things that I think we can say we achieved. Then on the challenges, supply for our normal activities, as I mentioned in the beginning, was very difficult. Just to have the access. The second part of it is, of course, also the financial part, as everything increased in price. Also, not all transport is available anymore, and this is not only the travel issues for the staff, this is also in terms of supply. So everything takes longer. Some of the staff, international staff, needs to go into quarantine. Some of the local staff, they cannot move from one province to the other, depending on the measures taken in the different country. Now people need to get tested before they arrive somewhere. Not all tests are as reliable as we know them in our home country. So people get false negative, they get refused, have to be sent back. So that gives a delay, of course, for the project. It gives also financial stress, and that's difficult. So the quarantine, this is similar. It's a similar challenge for the MSF international staff, of course, because when they come back, they need to go most of the times in quarantine, or sometimes staff, local staff, when they are suspected cases, or if there is a confirmed case, of course, within their vicinity, they need to go in quarantine. So that means a lot less HR available. And that brings us to the last point, of course, that's the staff health, which for us has always been one of the priorities, if not the main priority, because if you don't have healthy staff, you cannot treat any patient. And that's very complex. When we look at our staff, we have a lot of people above 65 also, and people with underlying conditions. So that's the main challenge, a big challenge. So just to give the example of Yemen, Yemen is a war-torn context for almost 10 years now. We set up a couple of treatment centers, also where we actually did the treatment ourselves. We put up a couple of isolation units. This is an existing hospital where we just put up an additional 11 beds, where we then attach our service to an existing hospital, of course. which always makes it easier, and where we treat patients. We put up a lot of screening points and triage, as I mentioned. All the other diseases are still ongoing, and especially in a country like Yemen, which is affected by the conflict, you have a lot of people coming in on emergency because of the fighting. And of course, somebody who has been shot or had a bomb blast or whatever, it's always difficult to ask, did you have COVID or didn't you have COVID? And then you have maybe one surgeon for a certain area. And then, of course, if that surgeon gets COVID, then you have no more possibility to treat these patients. So that's very important. No? So we put the IPC, so the infection prevention control measures, in place in every part that we were working or where we know health structures. We did a lot of training on case definition, treatment, and these protective measures. We also helped with referrals, because how do you do a very quick emergency referral by keeping in mind that the patient could have COVID? We put an ICU, so an intensive care unit up with an inpatient department in one of the hospitals. We looked at the waste management because, of course, all these masks and gowns, if they are not reusable, and especially the masks, they are not reusable, they need to be treated and destroyed. As I mentioned, this is the same everywhere. Supply always has been a very difficult issue for Yemen, because it's heavily controlled and there is a lot of front line, so you cannot bring your material whenever you want to wherever you want. So that's very challenging. We did a lot of health promotion, of course. And then in total, we have support on 10 hospitals still running at the moment, and there were 4 projects that along the way we could close down because the situation also had calmed down. Then a very small last part on migration, as it's one of the more vulnerable populations. So we have search and rescue activities in the Mediterranean, in Europe, with Greece. Maybe you have seen the last couple of weeks where there was the big fire in one of the camps. Of course, Bangladesh with the Rohingya camp, and then Venezuela and the countries around as some of the main activities on migration. There's a lot more, but those are the main. One of our focus is the advocacy of the precarious health situation, which is very obvious. If you have to wear, if you have to do social distancing of 1.5 meters, and you're living in a confined space, this is extremely difficult. Wash your hands. But you have one water point, for example, in Bangladesh, you have one water point for 300 people. So you cannot expect everybody to wash their hands constantly. And sometimes they even have to walk towards the water point. It's not like we can do in our safe space or in our house or in our office, where you have a water point almost everywhere. They have to walk maybe 100 meters before they can wash their hands. So these situations are very precarious, and it's very difficult for the people also to follow every guideline that is mentioned. Like in Bangladesh, for example, then what did we do? We did a lot of health education. We tried to sit down with the community to see how we could better prepare the camp for the potential arrival of COVID, which did in the end. And we had a treatment center that we used for a different disease a couple of years ago for diphtheria. We had like a 300-bed unit that we transformed to a COVID unit. Then as a last example, for Malaysia in Penang, we did a lot of health education in the different languages for the different people from Rohingya and Burmese, because this is always an issue. People tend to forget that the information that you deliver is not always understandable for everybody. So that's the first step. And then, of course, when people arrive in the hospital, and that's also what we did in Penang, is that we offer translation services. It's very important, especially also for COVID, when we talk about contact tracing, when we talk about who you have been in contact with, where you have been, also that this is well known towards the health provider, but also that the patient who comes in can do his story correctly. So a lot of health promotion with a local organization which called Our Vision, which is an online Rohingya news network. And this is always important, of course, that we link ourselves to any local organization or the population itself, because that's how you better understand the needs and the challenges. And then, yeah, of course, the provision of health and hygiene kits, because a lot of times, I give the example, for example, so in Bangladesh, the big camps, they are already quite isolated, and they get completely surrounded and shut down, and nobody can enter inside or outside, and they do depend on support. So we did also in Penang a provision of health and hygiene kits. Voilà, and I think I will give the word then to Vivi.
Hi, thank you, Gert. Hello, everyone. My name is Vivi. I was the project coordinator for the Abdurafi project in Ethiopia. Just before I start, I'd like to thank Swiss Cham and the MSF teams for organizing this event and inviting me and Gert to share. Also, a big thanks to all of you for taking your time to be here today. I know for some of you in Singapore, it's lunchtime, and then for those of you not in the same time zone, thank you for being here today as well. So Gert did the macro picture. I'm going to give you the micro with a slice of where I did my last mission, which is Abdurafi, Ethiopia. That red pin there, that's the Abdurafi location within Ethiopia. As you can see, it's on the border, and it's in the northwest corner of northeast corner of Ethiopia. Next. So it's in the Amhara region, which is like a state for Aussies. You can think of it as states. So it's one of 9 states, within one of 9 states. And within the Amhara region, so I've tried to highlight there just Abdurafi. It shares 2 borders. There's an international border with between Sudan and Ethiopia, then a regional border, so a state border between Amhara and Tigray. And because the nearest large town was actually in the Tigray region, it meant that we were very dependent on going to the Tigray region back and forth for medical referrals, for supplies, and for transit for us to come from the capital Addis Ababa to the project back and forth. Yeah, so these are just some things for you to keep in mind. Again, with COVID, all borders, including regional borders, close up. Next. Yeah, that whole area that you saw, that's all very arable, very fertile farmland. A lot of agricultural activity goes on, especially cotton, sorghum, and wheat. And this is, he's a prime example of one of the people that works there. They are dependent on a migrant workforce. So it's a very transient workforce that comes in for a part of the year, and that's exactly how they work in the field. So that's a sickle in his hand, and you can see he's wearing the Orthodox Christian cross. And yeah, there's no protection, there's no gloves, there's nothing. It doesn't show his feet, but on his feet, he's just wearing flip-flops or slippers, not boots or anything like that. Next. Yeah. So for MSF, what we did in that region was Kalaza and snakebite. That's what we were working on. That's what we treated, because they were neglected tropical diseases. So So Kalaza is also known as black fever. It's the second most deadly tropical disease after malaria. And then snakebite, you can see one of the victims there. It gets very puffy. The face because that's where she's bitten, can be venomous or envenom, dry or envenom snakebite. Next. So yeah, that's just setting the scene for you on Abdul Rafi and what we were doing there. And I'll go into COVID a little bit. For COVID, the first case was confirmed in mid-March. And I was actually the first MSF staff to come back from quarantine. And I went into quarantine for MSF, not for the government at that point. And one of the first things I did was I retasked our health promotion team. So something Gert mentioned earlier about health promotion. So this is one of our normal activities that we do. Our teams on the ground, they're talking to the migrant workers about snakebite and about Al-Azhar. But now with COVID, we retasked the messaging and we said, talk about IPC, infection prevention control, talk about hand washing, and talk about social distancing. Next. We also printed hand washing posters. You'll see an example of that later. But just before that, I'd like to show you. So this is something the project team did in Abu Rafi. We were in the vehicle and I was talking to the team and said, you know, guys, everyone's washing their hands, but everyone's touching the faucet. So the driver heard me, and when he came back to the project, he worked on creating this. On the left is a pedal-operated hand washing point. So the black pedal, the red and black pedal at the bottom, I'm not sure if you can see it, you press on that, and then the water comes from the faucet. And on the right is also a pedal-operated device. It's a pedal-operated water station. So you get cold drinking water, and you get to wash your hands without touching the faucet. So that's the driver there, Ashwar, very talented guy. So I thought only fair that I show him, the innovator. Next. He went a step further and he said, all right, I'll do something. And I'm not sure if you can see, that's my boot. I'm trying to pull down on the soap dispenser. So essentially he created a system where you could wash your hands, get the soap and the water without touching any of the devices, containers. Next. This is a picture of our office, and if you can imagine a little bit, this space used to hold 16 staff members, and then because of COVID, we had to rearrange it. We spaced out all the desks, and then it holds now 5 to 6 staff members, and the rest we had to build an entire new office and move them there. We also did trainings for the government health care workers. So one of the priorities that Gert mentioned earlier about supporting the authorities. So this is something in the field. This is how we support the authorities. Our staff go out, and yeah, this is a bunch of the healthcare workers from the government sector. And especially because we were hearing stories about healthcare workers running away from their facilities when they had a suspected COVID patient, even though they haven't tested. So we thought by training them, by making them more aware and more informed, that they would be less likely to run away. One of my jobs as the project coordinator was to also give advice and advocacy with the various levels of government and local stakeholders and leaders. So again, it's something that Gert mentioned, we support in different levels. So we train the healthcare workers on one end, and I try to work with the leaders on the other hand to share with them my knowledge on public health, to share with them just the advice that MSF and all WHO has been giving on washing hands, on IPC. One of the challenges though with Ethiopia, with Abu Rafi especially, is that they're very religious, and what you see in the example in that picture there, this is actually very common. It's called cross kissing, and that's a lady, she's gone up to a priest and she's kissed the Orthodox cross. It does not happen only in a church. This can happen anywhere. But again, that means that the cross can become a point of transmission if everyone's making contact with it. So it's very hard to try and explain to them, look, we're not against your religious practices, but is there a way you could try this differently? Is there something you could do to change? So there's a lot of back and forth, a lot of advocacy with them on these issues. Next. The other challenge, so this is more an annual challenge, but also with COVID now compounded a little bit, is that with the onset of the wet season, we get a lot of creepy crawlies in Abu Rafi and in the compound, in our compound as well. So that is a baby black mamba that one of our watchmen killed on the night rounds, and then he showed it to me in the morning. So yeah, these kind of visitors, snakes, scorpions. We had a locust swarm at one point coming by our compound. And there was also a water shortage. So you think rainy season, why is there water shortage? Because the town takes their water from a river, and the way they do that, I tried to capture it with an image there. That's a slow sand filter. And slow sand filters don't work too well with muddy water. So the rain created all this muddy water, and now they have, the slow sand filters can't filter them well enough, and there's a shortage in town. So these are all just compounding onto COVID. So we go on to July and August. This is one of our staff, nursing staff. They're already wearing masks in the ward. This was pretty much mandatory. And then next, but we also then said, start wearing masks in the office, everywhere, in the project site, everywhere in the compound. This is a donning room. So staff report for duty, take off their cloth mask, put it in their envelope, which is personalized, and then they don a surgical mask and a face shield there. And on the other side of that room was the doffing. This is one of our wards. So another challenge again. So with all these challenges, and this is actually something that also mentioned. So one of our priorities was to continue essential medical services. In this case, snake bite, because it wasn't handled by the government, it was neglected, and it was our responsibility. But at the same time, another challenge was that supply and getting supplies to the project has been a problem. So this is a picture of one of our wards, and this is when we had a rupture of anti-venom. So to say that we were a snake bite project and to have this time where we didn't have any anti-venom, it was very demoralizing for the team. It was demoralizing for the patients as well. We saw a decrease. So all these beds would have normally been full, but in this case, only 1 or 2 patients came. We still did what we could while waiting for the anti-venom to arrive. Next. So these are some of the posters that I mentioned earlier. Luckily, MSF being this large international organization, we do things somewhat in unison. So So these were posters designed by our media team, and they put it up on the website. All we had to do was take them down and then put up Amharic text, and we put them all over the town and the project as well. Next. So yeah, this is a typical MSF setup in the field. I think Gert is very familiar with this, and maybe some of you as well. So we use a lot of plastic sheeting, wooden poles, and this is our COVID isolation unit. It's a 10-bed unit. MSF in that setting, we were not allowed to treat COVID patients ourselves, but in the interim between identifying a suspected COVID patient and waiting for the government to pick them up, we set up this facility. So we have a 8-bed, a larger ward for suspected patients, and then a 2-bed smaller ward with confirmed patients who need oxygen concentrators. And this is one of the rooms in the ward. Very simple setup, plastic sheeting wall with a bed. The staff walks up and down the hallway. There are no doors, so the staff can just look from the hallways how the patients are doing, and if necessary, they would step in to help them out. So finally, this is as I was leaving the project in August, we were getting desperate. All these different things we were doing, the advocacy, the lobbying, the health promotion, but there was very little uptake in the community. People were not wearing masks, people were not washing hands, there were not even enough necessarily hand washing points that were maintained. And in our desperation, I told the team, you know what, let's just take a step back. Let's do something for ourselves as an MSF team. So we did a small team building event. That yellow line represents the one major road that runs through Abu Rafi, about 3 kilometers in length. We took a walk on that one major road wearing our identification, so MSF vest, a t-shirt, and a mask. It was a passive measure. It wasn't meant to, we weren't actively promoting wearing masks. We just said, this is what we are doing. And that's the team there, about 30 staff volunteered for the walk. And then 2 weeks after the walk, next, the youth in the town did their very own march. So they got 2 lines, distance, wearing masks, even wearing high visibility clothes to draw some attention to themselves. Next. So for us, this was mission accomplished. Essentially because that's what we've been trying to angle for since day one. We wanted the community to uptake and do the messaging themselves, to do the practices themselves, to wear the mask themselves. So this is very positive to see, just before I left, to see the towns, people, the youth themselves were getting involved. All right, next. So this was done before COVID. So yeah, thank you for your time. Any questions?
Thank you very much, Vivi, for this impression, which takes us really a bit with you to such a mission. I understand you're back now in Singapore, right? So
yeah.
So you're back from that mission.
Yeah. I ended my mission. I'm actually I am resident in Australia, but it's actually one of the problems that Gert also mentioned in his PowerPoint about staff travel. So I couldn't get a flight back to Australia. And in my long detour, I had to come to Singapore first. And I'm waiting, I think it's about 10 days now before my flight to Perth.
Oh, okay, all right. So enjoy Singapore then.
Thank you.
All right. So thank you very much, Vivi. Thank you very much, Gert, and thank you very much, Karu, for that good overview about the activities and a little bit the positioning of MSF. And yes, we do have a couple of questions which come along. So maybe just to start with the questions which are coming from the audience. So there is the question about as well a bit the positioning, or let's say the scope of MSF, which I think is quite an interesting one, and how does it compare to the International Committee of Red Cross, for example, or other organization, and how to treat with overlap coordinations, maybe especially in this difficult time of COVID-19, where there's a lot of limitations. So that's probably a question for Karu or Gert, operational wise. Also about the how the staff is equipped with survival kits like food, water, medicine, and so on. So maybe Gert can give us a bit an update on that one. And then maybe as well for Gert comes the question about where are the hotspots actually, if we look to the Asia Pacific region. I think you mentioned Malaysia, you mentioned some others, but which are the hotspots actually?
Yes, let's start with the scope and then to see with all the other organizations. I think a lot of it depends on where you are. We're always in support of the government, whether it's a strong government or a less strong government. It's always in support. We're always in contact with all the other organizations. Of course, as mentioned, ICRC, so the International Red Cross, is one of the actors where we normally work with. The idea is always to be complementary rather than to an overlap. We have seen that, for example, in the very early stage where everybody came with different guidelines, and it was the guideline of WHO, it was the guideline of MSF, it was the guideline of ICRC, it was the guideline of the government, while in the end they were all the same. So you could say use the one that is more current. So we always try to be complementary. With bigger NGOs and the government, it's always easier. With smaller NGOs who are less coordinated, of course, who have a smaller scope anyway, it's sometimes a little bit more difficult. So we do that anyway. In most of the regions, it's possible through Zoom, like we do now. So that's also a bit of the advantage that we have, that COVID did not really stop this kind of communication that we have. So that's on that question. What are the current hotspots? What are the current hotspots in the Asia Pacific region? It's a very big region, of course. I think India, as you all know, is one of the biggest hotspots at the moment. Of course, the population is also the highest, and then we have, of course, Indonesia, Philippines, more closer to Singapore. So those are the hotspots. Again, it depends also on the space and the needs. Of course, it's first the needs, and then it's the space that we can have as an organization, whether we can or cannot work there. Anyway, what we do, like in Indonesia, we have our own projects where we integrated COVID-19, as well as in the Philippines. But in the Philippines also we did a broader health promotion and support to several structures within Manila. How is your staff equipped? I find survival kits a bit harsh. No, our teams are always fully supported. As mentioned in the very early stage, this is also why we have staff that is specialized in HR, in logistics, to make sure, in supply, to make sure that this is not an issue. Food, water is always local. Of course, sometimes water needs to be treated. Then you have all these water and sanitation specialists that come in the picture. And medicine, yeah, this is supply. And as I mentioned earlier, this has always been quite of a challenge for certain places where access is more difficult, especially in terms of conflict. But yeah, normally we provide staff with housing, food, and everything, and all the support, medical support, also for themselves in case of need, especially in the early stage when there was very little known. We have reference all over the world that could evaluate cases and to support the teams on the ground. So what do we do with this person who is sick, who is potentially COVID? How do we isolate? Do we put everybody in quarantine? So those kind of support is always there. So I hope that more or less answers that question.
Yes, certainly. Maybe you want to share about the hotspots in Asia Pacific.
Well, I think in Asia Pacific, as I mentioned, I think it's India.
Okay.
And Indonesia, Philippines are still there. Of course, these are the most populated countries, or also the ones with the most movement or the most accessible somehow. So it's not that surprising, to be honest.
Okay, talking about accessibility, and so there's a quite an interesting thought coming along here as well, from somebody from the audience talking about, let's say, a bit of a digitalization, I would call it. So having today's technology, Wi-Fi, and so on, are there any? There are two questions. So how good is Wi-Fi available for most residents in badly affected areas, and does the government policy whether they allow cross-boundary diagnosis? So sounds for me to use digitalization technology as well on your field? So maybe as well a question for you, Gert. Yeah.
Yeah, and I think maybe we can give more concrete examples, but just very quickly, I think Wi-Fi or 4G anywhere in the world nowadays becomes more and more accessible. Not going to say it's one of our main priorities, but it really helps operations also in terms of support, in terms of data, in terms of supply. So yes, it is available very widely. Only places where we have some issues sometimes are after disasters, because of course everything is down. And then the cross border or the consultation, of course, remote triage. Triage is not gonna is not gonna give you the right diagnosis, of course. We do have projects where we do consultation from abroad or from further away. But for COVID, this is not really recommendable. I think testing is, of course, the first option. But I think maybe if we can give some example from the field.
Sure, thank you, Gert. Yeah, so the 4G, the Wi-Fi, the connections, it's very much dependent on context. Some context is, yes, in general, there's a lot more penetration of connections everywhere and people are able to connect, but there are still places in the world where connection is not very reliable. In terms of cross-boundary diagnosis, I don't really have an example for that, but what I can give an example of is, so yeah, where we were operating about 150 kilometers away, they were setting up a large government facility for quarantine and isolation. And they didn't know what to do. So again, coming back to a point I mentioned and Gert mentioned earlier, how do we support government authorities? So we don't want to necessarily risk our exposure by traveling all the way there, but we have good enough 3G, 4G connections. So we got on the phone with them and then we first used the phone to just talk to them, and then we did a video call where they walked around and they showed us what they had. And then we said, okay, we think you can set up a screening area here. We think you can do that fencing there. You can have separate shower block there and the trees there. So we gave advice to the government on how they can do better quarantine facilities.
Thank you, Vivi and Gert, for those answers. We are already coming to an end, but before I want to close the question, so I have something which I would also like to raise or to discuss, maybe with Karu, coming back to since you are the philanthropy director or officer. So all that what we heard about and all these projects and so many operational setups which you have to organize and so on as an organization. So that is also something which costs money. And we know that mainly you are financed by donations. Maybe how does that work actually? And since there is probably more to do for you as well due to this COVID, and how does that play in? And on the other side, maybe as well to with the knowledge that we have now a couple of people as well on the line coming from organizations, from economic and so on. What do you expect from us, or how can we support your organization and your well-doing?
Yes, thanks, George, for that question. So as I mentioned earlier, more than 90% of our funding actually comes from private sources. So that's individuals like you and me, and also corporates play a big role in this as well. So if there are any of you that are particularly interested in supporting our COVID-19 efforts, we actually have launched a COVID-19 Crisis Fund, which is now being used to support all of MSF's COVID-19 response, as well as just manage the impact of COVID-19 on our existing medical projects. So after this session, if you'd like to get in touch with either Flaminia and myself, so Sarah, if you could go to the last slide, I think the contact details would be there. Yes. So for the companies that are in Singapore, if you'd like to find out how you can collaborate with MSF, you can get in touch with either Flaminia or myself. And we also have our philanthropy officers from Hong Kong and Australia here as well. I mean, like the philanthropy team from there as well. So I don't know, Grace and Ruth, if you might just want to turn on your cameras and say hi to everyone. Anyway, but if you guys are from the Hong Kong, like companies in Hong Kong or Australia, please feel free to reach out to them, and if they will be able to share more about what MSF is doing in your respective countries as well. So yeah, do get in touch with us, and we'd love to share.
We can't put the video on, but we can say thank you very, very much for your interest, Ruth from Australia here. And yeah, very, very much welcoming of any contact if you'd like more information. Thank you.
Yeah, and I'm Grace from Hong Kong. Thank you so much for attending. Yeah, if you want to get in touch, we're here as well. So thanks for coming and listening.
Good, thank you very much to you as well, to the kind words. And so that brings us to an end. So thank you very much for sharing these great activities together with us. I think it's always interesting as well to see a bit behind the scene when we all read about, but maybe what that means as well, and what kind of effort is necessary to help everybody. And that is an absolutely great thing you're doing. We are happy that we can be part of it, a bit of it, and hopefully as well help you in supporting to do so good also in future. So thank you very much, Karu. Thank you very much, Kurt. Thank you very much, Vivi, for your presentations and for your words. Thank you very much to the audience for listening, for being here. And we will share this information about the contacts certainly as well on our homepage, so that everybody who wants to get in contact will also have the information available. Thank you very much to everybody, and have a great day.